I'd like to welcome you to the remainder of our morning session and read to you again some of the announcements some of you may have missed this morning. I want to remind you about tonight at 6 o'clock, the George S. Eccles Dinosaur Park Family Night Buffet sponsored by McCady Hospital. Thursday is the second revival of the Ladies' Social, Luncheon, and Fashion Show sponsored by the Weber County Medical Society and Alliance. All partners and guests are invited. And Thursday night is the President's Reception sponsored by Ogden Regional Medical Center starting at 6:30 in the Union Station Old Timers Room with comedian Craig Billick and singer-entertainer Pam Cahoon. Thursday night is also the Utah Academy of Family Physician annual meeting with a reception and dinner starting at 5 o'clock in the junior conference room. I want to remind you to please mute and vibrate all cell phones and introduce our next speaker. Dr. Samaddar received his medical degree from the University of Toronto, where he also completed his internal medicine residency. He subsequently completed a fellowship in gastroenterology at the University of Michigan and an advanced endoscopy fellowship at the Mayo Clinic. During his gastroenterology fellowship, Dr. Samaddar also completed his master's in healthcare research at the University of Michigan Medical School and obtained specialized training in cancer genetics at the University of Michigan Comprehensive Cancer Center under the mentorship of Dr. Stephen Gruber. He is a fellow of the Royal College of Physicians and Surgeons of Canada. His research focuses on the genetic epidemiology and outcomes of patients with hereditary colorectal and pancreatic cancer. Dr. Samaddar has published and presented at national meetings on the increased risk of colon cancer associated with various genetic lifestyle factors and chronic diseases and opportunities for chemoprevention. Dr. Samaddar's special interests are in hereditary gastrointestinal cancer and endoscopic oncology. He co-directs the Familial Colon Cancer Clinic at Huntsman Cancer Institute with Dr. Randall Burt. He performs both general and therapeutic endoscopy. Let us welcome Dr. Samaddar.
Thank you to the organizers for having me come out and talk to you guys today, especially to Chad, who I've known for the last 2 years now and collaborated quite a bit with patients with a higher risk for cancer predisposition. So what I'm going to try and talk to you about today is the various syndromes or disorders that confer an increased risk of colorectal or other GI cancers and are namely genetic causes. So my disclosures, not really anything of commercial relevance to this presentation. So when we think about colorectal cancer syndromes, we place them into 3 or 4 different groups. So the adenomatous polyp syndromes, these are ones where you get many adenomatous polyps. Lynch syndrome, familial adenomatous polyposis or FAP, a more rare entity called MYH-associated polyposis. And we'll talk about each of those briefly today. The second one is serrated polyposis syndrome. This is one that is probably scaring gastroenterologists because it's very hard to detect these serrated polyps, and it's thought that they are the main reason why colonoscopy is not 100% protective, why there is a missed cancer rate at colonoscopy. We'll very briefly talk about the hamartomatous polyp syndromes, things that you might have heard of from medical school, Poitz-Jeghers syndrome, juvenile polyposis, Cowden syndrome. These are very rare, account for less than 1% of all colon cancer. And we'll end by talking about what's called common familial colorectal cancer, which is the majority of patients that you'll see in your practice who have a family history of colorectal cancer that increases their risk, but do not have a defined genetic syndrome. So when we look at the pie chart for colorectal cancer, the vast majority, the yellow section, is sporadic colorectal cancer. This accounts for about 70% of all colorectal cancer. This means that there's no identifiable single genetic cause, single environmental cause. It's probably a combination of all of those. Familial is what I was talking about. Common familial colorectal cancer is about 25 to 30% of all colorectal cancer. This is patients who have at least one first-degree relative with colorectal cancer. That increases their risk 2 to 3-fold of getting colorectal cancer. but no one defined genetic syndrome accounts for it. And then the bottom parts are Lynch syndrome, familial adenomatous pulposus, hamartomatous pulposus. These known genetic syndromes account for about 5% of all colorectal cancer. I'm going to start by looking at Lynch syndrome, which is the largest component of this. Lynch is about 2 to 4% of all colorectal cancer. It's named after Henry Lynch, who is still at Creighton University in Nebraska, and described family G, which is the family that had a combination of colorectal cancer and uterine cancer and came to be known as the prototypic family for Lynch syndrome. The prior name for Lynch syndrome you may have heard was HNPCC, hereditary non-polyposis colorectal cancer. This name is going out of not fashion, it's just going out of use. We're going back to the use of Lynch syndrome. Knowing about Lynch syndrome doesn't just affect gastroenterologists or even primary care doctors, but also gynecologists because of the endometrial cancer component. So whenever we think about any hereditary cancer, the things that I always ask myself when I see a patient or family is, what is the strength of the family history? Are there young ages of diagnosis? So when we mean young age in colon cancer, we usually talk about less than 50 years old. Are there individuals with more than one primary cancer? So if you have a patient who you're seeing with colon cancer and uterus cancer, or colon cancer and brain cancer, you need to start thinking about hereditary syndromes. Are there presence of certain cancers clustering together in a particular person or their family? This is prototypically colon cancer and endometrial cancer, or uterus cancer. If those two occur in the same family at young ages or in the same person, you want to think about Lynch syndrome. And the presence of rare cancers. So when we talk about rare cancers, these are some of these brain cancers like glioblastoma, medulloblastoma in a young person can make you think of Lynch syndrome. Sebaceous carcinoma, sebaceous adenoma, which dermatologists will often refer to our practice for workup of Lynch syndrome. Rare kidney cancers called ureteric cancers. It's not the normal renal cell. It's cancer of the ureter. And again, it's quite rare and associated with Lynch syndrome. So when we think about the risk of colorectal cancer in these various syndromes, you can see in this bar graph here, an FAP, because they get hundreds to, if not thousands of polyps in their colon, their lifetime risk of colorectal cancer is essentially 99 to 100%, and therefore they're treated with colectomy at a fairly young age. Lynch syndrome, the risk of colorectal cancer is about 70 to 80%, and you can see lower in Peutz-Jeghers, juvenile pulposus, Cowden syndrome, somewhere around a 20 to 40% lifetime risk of colon cancer. This is a typical family pedigree for a Lynch syndrome. You can see the index patient is the woman with the yellow circle, diagnosed at age 35 with colon cancer. Her mother has endometrial cancer at age 50. And again, so you have the clustering of cancers at a young age, and you have a clustering of both endometrial and colon cancer, making you think of Lynch syndrome. So HNPCC, which is now more often referred to as Lynch syndrome, has an early age of diagnosis with an average age for colorectal cancer diagnosis of 44 years. Predominantly, they will have right-sided colonic lesions. So this is in the cecum, the ascending colon, the transverse colon. The lifetime risk of colorectal cancer, as I said, was 70 to 80%. The lifetime risk of uterine or endometrial cancer is about 40 to 50% lifetime risk. It's autosomal dominant inheritance, meaning if you have it, your child has a 50% risk of also having Lynch syndrome. It includes a number of other cancers other than colon and endometrial, which are the typical ones, including ovarian, renal pelvis, ureteric, stomach, and small bowel cancer, brain cancer rarely as well. So this is the risk of the various cancers in Lynch syndrome. You can see endometrial is 40%, ovarian 10%, gastric 20%, urinary tract 10% lifetime risk, all the way down to small bowel cancer, which is a very rare cancer. It's still about 5% lifetime risk. There are some eponyms associated with Lynch syndrome, some more rare kind of variants that people have termed. One is called Turcot syndrome. Turcot syndrome is when you get a combination of multiple colorectal cancers and primary brain tumors in the family, specifically glioblastoma. That's a combination of colon cancer and brain cancer in the family. Again, it's Lynch syndrome. It was called Turcot syndrome. That term has now gone out of use. The main reason for that is people would also refer to Turcotte syndrome in families where there's FAP, familial adenomatous polyposis, along with brain cancer. We know the genetics of these two disorders are completely different, so the use of the term Turcotte has gone out of favor. Muir-Torre syndrome. This is still often the referring request from dermatologists. They will send us letters saying work up for Muir-Torre syndrome and not Lynch syndrome. But it's basically typical features of Lynch syndrome in terms of a family history of colon cancer, rectal cancer, endometrial cancer. But the dermatologic features are most prominent. Sebaceous gland tumors, which are sebaceous carcinomas, sebaceous adenomas, and keratoacanthinomas. And you can see some of the pictures here. I would say majority of the time this is a dermatologic. A dermatologist or someone very good at skin findings is picking this up, has done a shave biopsy or something like this, and it's been read by derm pathology as a sebaceous adenoma or carcinoma. Pathologists have actually become very savvy. They, at least at ARUP and at the Intermountain sites, if a pathologist reads a sebaceous carcinoma out of ARUP, they will write on it that this patient is at risk of Lynch syndrome. You should refer to a genetic counselor or a cancer genetics clinic. So this is the genetics of Lynch syndrome. Autosomal dominant inheritance. So you have the affected father in green, who has one abnormal chromosome with the affected Lynch syndrome gene, one normal chromosome, which is pink colored, and then the mother who does not have Lynch syndrome has two normal copies of the gene. You can see that the children, therefore, through Mendelian inheritance, have a 50% risk of getting the affected or mutant gene from the father and therefore having Lynch syndrome. The genes that are involved in Lynch syndrome are called DNA mismatch repair genes. MMR is the short form. There are 4 of them that are known: MLH1, MSH2, MSH6, PMS2. There's one additional gene that's now tested for EpCAM, which in itself does not cause Lynch syndrome, but it is a gene upstream of MSH2, and a mutation in EpCAM shuts off the transcription of MSH2. So effectively it causes Lynch syndrome. So what do these mismatch repair genes do? Well, when our DNA is replicating from one cell to the sister cell, mistakes occur. As the DNA polymerases come around, we know that nucleotides are mismatched. Normally, our bodies have spell checkers. That's what these 4 mismatch repair genes are. They come around and look at the replicated strand of DNA and make sure it is a 100% match of the original strand. If not, they have the ability to extract the nucleotide and put the correct nucleotide in. If we have a defective mismatch repair machinery, meaning one of those 4 mismatch repair genes, subsequently proteins, is missing, defective, or deficient, errors start accumulating in our DNA replication process. If that error occurs in a gene that is important for cell division or cell proliferation, you have a risk of getting cancer. So that's how these genes contribute to Lynch syndrome and to cancers in Lynch syndrome. Why is colon cancer so common in Lynch syndrome? It's because the colon, the cell lining of the colon, rejuvenates more than almost any other lining or cell type in our body. So there's more chance of errors accumulating in a colon cell than in a cell in the brain or in the kidney or anywhere else. We talk about microsatellite instability as a feature of certain colorectal cancers, which can lead you to a diagnosis of Lynch syndrome. So Huntsman Cancer Center and Intermountain Healthcare, to a large extent, have now made it that any colorectal cancer, regardless of age, will have automatic microsatellite instability or immunohistochemistry testing done. So this is regardless of the physician, the surgeon, the oncologist, the gastroenterologist asking for it. It's done as a standard of care by the pathologists now, by the molecular pathology laboratories. So what is microsatellite instability? As you will see, this comes back on path reports. Microsatellites are areas of essentially small repeats in our DNA. Junk DNA, they're combinations of just long adenosine residues or AT residues or GC guanine, cytosine residues in long sequences. Again, in the replication process, if there's a defect in the mismatch repair machinery, these long repeats will get longer and longer and longer. That's called microsatellite instability, that these repeats are longer than in the adjacent normal tissue that they have a sample as a comparison. So We know about 10 to 15% of sporadic tumors have microsatellite instability, but more importantly, 95% of all Lynch syndrome cancers have microsatellite instability. Therefore, it's a good feature to further the workup of Lynch syndrome. A signature that can tell you Lynch syndrome may be playing a role in this cancer, work it up further. Lynch syndrome, so if we have microsatellite instability on the tumor, the next test we do is called immunohistochemistry. So each of the 4 mismatch repair proteins or genes I talked about, we have antibodies that are fluorescent labeled or labeled with a colored dye that the pathologist will stain the tumor samples with. If all 4 proteins are present, it's unlikely to be Lynch syndrome. However, if immunohistochemistry shows that one of them is missing and the other 3 are present, again, it's suggestive of Lynch syndrome, and more importantly, it can tell you which gene to go on and sequence then. So you can see in this picture here, on the left-hand side, you have normal staining for the MLH1 protein in the tumor tissue. But on the right side, when they stain the same tumor tissue with the MSH2 antibody, you can see it's not reactive. You don't have the little brown spots or red-brown spots to suggest the antibody sticking there. So MSH2 is likely deficient in this tumor. Our next step would be to go on to germline sequencing. We would get a blood sample from the patient and do full sequencing of the MSH2 gene, looking for a mutation or a deletion of an exon, for example, to confirm a molecular diagnosis of Lynch syndrome. With the microsatellite instability and immunohistochemistry, we'll often sign it off as this patient or family meets a clinical diagnosis of Lynch syndrome and we're awaiting the molecular diagnosis. Why do we start with microsatellite instability and immunohistochemistry first? Because they're cheap. In general, immunohistochemistry, MSI testing is about $500 on a tumor sample, and for whatever reason, insurance companies don't like doing genetic tests, but they'll allow us to do MSI and immunohistochemistry on a tumor sample. They're not counted as genetic tests. But once you have that abnormal result, the insurance companies are obligated to do the genetic test. The genetic test for every gene you sequence, so if there's 4 of these mismatch repair genes, each one is $1,500 to $2,000. So we like having the immunohistochemistry first so that we can figure out which protein is deficient, most likely, MSH2 in this case, and sequence that gene only, instead of doing all 4 and spending $6,000. So going back, actually one last thing. If microsatellite instability and immunohistochemistry together, if both tests are done, are 95% sensitive for Lynch syndrome, meaning if both tests are negative, we'll stop. Even if the family history is fairly strong, we'll stop. There's a less than 5% chance that family has Lynch syndrome if both tests are negative. So surveillance recommendations for patients with Lynch syndrome are colonoscopy starting at age 20 and repeating annually. So this is why it's important if you do diagnose Lynch syndrome in the index patient to find out if the children, the siblings carried a genetic mutation, is you would offer them colonoscopy annually starting at 20. Endometrial cancer and ovarian cancer. The guidelines for this right now are very up in the air. The recommendations are transvaginal ultrasound, endometrial biopsy, CA-125, and after the women have past their childbearing years, consideration of a prophylactic hysterectomy and oophorectomy. I say the guidelines are up in the air because there's very little evidence to support those recommendations for the prevention of endometrial cancer other than the hysterectomy and oophorectomy, obviously. Transvaginal ultrasound, endometrial biopsy have never been shown to be effective in the prevention of endometrial cancer. Ureteric or renal pelvis cancers, there's really no good screening modality. Some centers will do urine cytology, though I've yet to see one abnormal urine cytology in a Lynch syndrome patient that's led to a diagnosis of ureteric cancer. The impact of surveillance in terms of colorectal cancer in Lynch syndrome is well studied. So this is a study from Gastro done out of Johns Hopkins many years ago now in the 1990s, where they placed a group of Lynch syndrome patients in no surveillance and another group of Lynch syndrome patients in getting annual colonoscopy, which is the orange line. And you can see there's a difference in colorectal cancer incidence in the two groups. The group that got no surveillance in about 10 years had up to 12% had colorectal cancer versus 4% in the people getting annual colonoscopy. So even annual colonoscopy is not 100% preventative, is you can get interval cancers. For whatever reason, these microsatellite unstable Lynch syndrome tumors are very fast growing and can have been shown in several studies to grow between a 1-year colonoscopy period. The impact of survival with surveillance has also been studied in Lynch syndrome. So the Lynch syndrome patients who got no surveillance, which is the orange line, yellow line, and Lynch syndrome patients who got annual colonoscopy, you can see a survival difference. There was 65% reduction in mortality. So better survival, improved survival with the colonoscopy group. So that's why I was saying for Lynch syndrome, for colorectal cancer prevention with colonoscopy, there's very good evidence to support. None of the other things are evidence-based at this point. What I usually tell our fellows, our trainees, in terms of the diagnosis of Lynch syndrome is to remember this simple rule. It's called the Amsterdam 3210 rule. So 3 represents 3 or more relatives diagnosed with colorectal cancer or any other Lynch syndrome cancer. This is endometrial, small bowel, ureter, renal pelvis. 2 means 2 successive generations. This shows the heritability of cancer that's moving between 2 generations in the family tree. And you need 1 patient diagnosed at less than age 50. So this is the early onset cancer. And the 0 represents that you've ruled out familial polyposis. Someone's done a colonoscopy and seen that there's not hundreds of thousands of polyps in the colon. However, the failure to meet these criteria does not exclude a diagnosis of Lynch syndrome. This has been best shown that when you take a group of Lynch syndrome patients who are known to have Lynch syndrome with a molecular diagnosis for a mutation in one of these mismatch repair genes, at least 40% won't meet this criteria. So the criteria are good, but they're not perfect. They definitely are not sensitive, meaning they cannot rule out Lynch syndrome. So cost effectiveness for the best approach for diagnosis of Lynch syndrome. So people have written about, is it best for the gastroenterologist or the colorectal surgeon to take a good family history and work up patients with early onset colon cancer? And it's never been shown to be effective, meaning there are miss rates. So the most recent strategies have taken this all out of the clinician's hands and made it an approach that's done at the molecular pathology laboratory. So the best approach that's been shown in a number of cost-effectiveness studies is to test all colorectal cancer, regardless of age, to do an automatic test for immunohistochemistry on all colorectal cancer tissue to see if any of them are abnormal in their expression or deficient in their expression for one of these mismatch repair proteins. If they are, then that gets automatically sent to a cancer genetics counselor or a genetics clinic for workup, or at very least on the path report it's written that it's recommended that you work this patient up for Lynch syndrome. So the cost effectiveness of this approach is $35,000 per year of life saved. The way cost effectiveness analysis is done is we set a bar of $50,000. If something can save a year of life for less than $50,000, that's felt to be cost effective. Where did this number of $50,000 come from? Well, in the 1980s, when dialysis research was being done about the cost effectiveness of dialysis, $50,000 was set as the number there, that by putting someone with renal failure on dialysis, it would cost $50,000 for a year of life saved. Therefore, you should do it. It's cost effective. And everything's been kind of estimated compared to that. So this is the approach that's done at Huntsman right now. So if you have a newly diagnosed colon cancer and it goes to surgery, then routine tumor testing is offered on that automatically. If it's abnormal, it's automatically referred off to the genetics clinic at the hospital. If it's normal, someone from our genetics clinic will still review every family history of every colorectal cancer patient at Huntsman to make sure it doesn't meet the Amsterdam criteria or another criteria called the Bethesda guidelines to see if further testing should be offered. Genetic counseling is offered, and then if it's felt that it's strong enough, we would go on to offering germline testing in that patient or their family to confirm a molecular diagnosis of Lynch syndrome. If the patient does not go for surgery, then we apply the Bethesda guidelines or the Amsterdam criteria on the family history to see if they would warrant, again, going to a genetics clinic visit. Usually we have biopsy material. Someone's done a colonoscopy and biopsied the tumor. Then we treat it as if they've had surgery, meaning the tumor tissue will automatically be tested with immunohistochemistry. So just in the last 1 year that this program's been active, you can see there have been about 340 colorectal cancers that have been tested at Huntsman. Normal immunohistochemistry results in 309, 91% of them, so about 9% of abnormal results. And you can see we've had 11 patients where there's been a loss of MLH1, 10 with a loss of MSH2, 2 with a loss of MSH6. So those are at least families where they meet a clinical diagnosis of Lynch syndrome. We may or may not have been able to detect a mutation in all of them, and sometimes insurance won't pay for it. And it's one thing to do the $500 test, it's another thing to do a $1,500 or $2,000 genetic test. So if we can't do genetic testing or no mutations found, we will label them as clinical diagnosis of Lynch syndrome and treat them the same, though, in terms of family members undergoing colonoscopy at age 20 every year. The problem is, their family members, let's say their children or their siblings who are at 50% risk, there's no way for us to figure out which one has Lynch syndrome and which one doesn't. So we would tell everybody in the family to start screening at 20 if we couldn't confirm a molecular diagnosis. So there's very rarely something called biallelic mismatch repair mutations. That means somebody who has an inherited mutation in 2 different Lynch syndrome genes, 2 different mismatch repair genes. These people present in a very odd way. They usually have very early onset colon cancer, leukemias, brain tumors. They have signs of neurofibromatosis. Onset is typically in childhood. So this is very rare. You may or may not ever see it in your practice. We've only had 2 cases at Huntsman over the last 5 years, so it's definitely not common. The next group of disorders or syndromes we're going to talk about are the polyposis syndromes, namely familial adenomatous polyposis, MYH-associated polyposis, MAP, and briefly on serrated polyposis. So familial polyposis presents with hundreds, if not thousands, of polyps in the colon. So typical presentation, 42-year-old male presents with rectal bleeding. Colonoscopy reveals numerous polyps, too numerous to count. Most are less than a centimeter, but a few are larger, up to 2 centimeters in size. Again, you have autosomal dominant inheritance. The typical pedigree you'll find here is the affected individual, 42, that we're seeing in clinic. He's in black and not yellow because he doesn't have cancer yet. He has polyps, thousands of polyps. But his brother had colon cancer at 35 and also has a history of a desmoid tumor, which is a fibrous tumor that occurs in FAP. And you can see it's likely maternal side of the family that's coming from, with multiple affected relatives on the mom's side of the family with colon cancer. So the adenoma penetrance in these patients is 100%, and colon cancer risk is nearly 100% if left untreated. Majority of the classic cases are due to a mutation in the APC gene, a germline mutation in the APC gene. This is nice to know because the APC gene was actually discovered in Utah. FAP was first described in Utah. It used to be called Gardner syndrome, and it was Gardner and Burt who described Gardner syndrome. There was a separate group in Great Britain at St. Mark's Hospital who described FAP with nearly the same clinical phenotype. Gardner syndrome, the variant that occurs in Utah, they also had desmoid tumors, osteoma, some extraintestinal findings. That's why it's called Gardner syndrome. That group at Huntsman went on to then find the APC gene and confirm mutations in it that showed that Gardner syndrome, FAP, were the same disorder because the mutation or the gene responsible was the same. So that's a part of Utah trivia. The picture on the right-hand side you can see, that's a dilated pupil exam. Those black spots are called chirpy, congenital hypertrophy of the retinal pigment epithelium. This is a sign also of FAP. It's picked up on a dilated pupil exam by an ophthalmologist. I've never seen it on a non-dilated fundoscopy exam done in an office setting. But they're small blacks or brown or gray colored plaques that are on the retina. If you have multiple spots and they're in bilateral eyes, again, it should be worked up for familial polyposis. And we get a fair number of referrals every year from ophthalmologists for this finding. Usually it's a child who has had a lazy eye or some other issue that led to an ophthalmology visit, and then the ophthalmologist refers saying there's multiple chirpy plaques in the eye, work up for FAP. So the incidence of FAP, it's a very rare syndrome, 1 in 10,000 births, autosomal dominant. The APC gene is located in chromosome 5q. Even though it's autosomal dominant inheritance, not everybody has a family history. About a quarter to a third of patients will have no family history of colon cancer. Why is that? It's because that gene, the APC gene, is very unstable and you can get a spontaneous mutation in it. So once the egg and sperm fuse, mom and dad don't have FAP, the egg and sperm fuse, as it's dividing, a spontaneous mutation occurs in the APC gene that leads to the rest of the cells in that person's body having APC mutation, and therefore they have FAP, and they can transmit it to their children, but none of their siblings or parents have FAP. It's even been described that during the division of the embryonic cells, the embryonic stem cells, that the mutation occurs at such a point that only half the colon has FAP. So the colon, the right and left colon, come from two different embryonic stem cells. And that APC mutation must have occurred after these two embryonic stem cells for the right and left colon divided, meaning only the right colon or the left colon has FAP. And you can't detect it in that patient's blood. Is their blood or marrow comes from a different embryonic stem cell which has a normal APC gene. So the only way to diagnose it in those few cases is actually getting samples from the right colon and doing sequencing in that and proving that it's not in the left colon or in the blood. That's very interesting too. This is in FAP and APC mutation, people have tried to work on what's called genotype-phenotype correlations, meaning where the mutation is in the APC gene, does that predict the phenotype that the patient will have? There's, to some extent, truth in this. We know that mutations that are off on either arm of the gene, meaning the 5' arm or the 3' arm, at the distant ends, will lead to a phenotype called attenuated FAP, attenuated polyposis, where you'll get not thousands of polyps, but usually 100 polyps or so in the colon. They still are FAP, and they have about a 70% lifetime risk of colon cancer instead of 100% risk. So it's interesting where just a mutation in a different part of the gene can lead to a slightly altered phenotype. FAP, like Lynch syndrome, has a number of extracolonic cancers associated with it. The most important ones are periampullary tumors. These are tumors on the ampulla where the bile duct and the pancreas duct exit. So in an FAP patient, you should almost always put a side viewing endoscope down to examine the ampulla properly. The other tumors that they can get, pancreatic cancer, 2% lifetime risk, thyroid cancer has a 2% lifetime risk, gastric, brain cancer, and hepatoblastoma. So hepatoblastoma is a very rare pediatric liver cancer. If it does occur, you want to work them up for FAP, that patient or that patient's family. We recently had one patient with hepatoblastoma who underwent a liver transplant at the U, but it's very rare. It is not a common cancer at all. The recommendation, because that cancer occurs between 0 and 5 years of age in children, is for children with FAP to get abdominal ultrasound and AFP, alpha fetoprotein, every 6 months done. Most patients I see, if they have FAP and we do confirm it in their child at a young age like that, and we tell them about the hepatoblastoma risk, we'll go and get the ultrasound once and the AFP blood work once. But no one likes having their kid getting a blood draw, so we usually don't see them again. And they're convinced that the risk is rare enough that they're not worried too much about it. Do you want to play the video? Click on the thing. So this is just an interesting video of a patient that we had with an ampullary polyp. And you can see how we try to deal with it here. So we're using a side viewing endoscope. We're putting a snare out. So that's where the bile duct and pancreas duct exit. There's a large adenomatous polyp there. We're putting the snare around it, and we'll use cautery to cut it off. Looks easier than it is, and then the other major risk is that of pancreatitis that can occur because you could close off the pancreatic duct, or biliary obstruction from the edema can close off the bile duct. So once we cut it off, the next thing is we need to get access to both the bile duct and the pancreatic duct. So here we're using the sphincterotome to get into the ducts, injecting in contrast to make sure that the duct itself is clear, there's nothing blocking it. Perform a sphincterotomy, that's where we use electrical current to open up or cut the bile duct opening to make it wider so it cannot close down with the edema from what we've just done. And finally, we leave in plastic stents for at least 2 weeks to allow the edema to heal up, and then we'll come out and take the stents out. So some variants of FAP. So I talked a little bit about Gardner syndrome. This is the classic group described in Utah. It's FAP with a number of extraintestinal manifestations. This is usually desmoid tumors, osteomas. Turcotte syndrome, remember I talked about that with Lynch syndrome. That's a combination of FAP and medulloblastoma brain cancer. And that's why we don't use it, because the term is mistakenly used to describe colon cancer and brain cancer in two completely different genetic syndromes. Attenuated FAP that I mentioned briefly, where you get mutations in the distal arms of the APC gene that lead to 100 or so polyps instead of the thousands of polyps that you see, an older age of colon cancer onset, and a lifetime risk around 50 to 70% lifetime risk of colon cancer. You can see this is a radiograph of osteomas. They're a bit benign bony growths, usually in the mandible or in the skull in patients. So in FAP patients will always feel around their skull as well as their mandible. By itself, it doesn't do anything bad. We deal with it only if it's a cosmetic issue or it's compressing a nerve or some other structure that's important. This is a desmoid tumor being removed as surgery. So it's a large fibrous tumor. Often occurs in the abdomen, but can be anywhere. Again, we generally don't do anything about these tumors because they are not metastatic potential. We deal with them only, again, if they're causing a compression or some other symptom due to their enlarging size. So if they're causing a bowel obstruction or compressing a nerve, we would deal with it. The negative of dealing with it in surgery is wherever you take it out, it's going to regrow, and it's going to regrow bigger. In terms of medications that can be used to treat them, nothing works really well. People have used tamoxifen. It seems like these desmoid tumors express the estrogen receptor, so tamoxifen won't shrink them, but will generally stabilize their size. So that is sometimes utilized. So the screening for FAP patients. So once their colectomy is done, in FAP, usually around the time they're 18 to 20 years old is where we try and get them out to do a total abdominal colectomy with an ileal pouch anal anastomosis. That's the most common type of surgery. Usually the colorectal surgeons will still leave a small amount of rectum, a rectal cuff or a few inches of rectum. That area should be surveyed every 1 to 2 years with a flexible sigmoidoscopy. We usually start colonoscopy in a known FAP family at around 12 years old and scope the child every 2 years until we get to a point where there's 30 to 40 plus polyps that are not endoscopically removable. That's the point we refer for colectomy. That's our general term, is 30 to 40 polyps is the limit of what endoscopists can reliably remove, making sure that nothing's left in the colon. To duodenal or periampullary surveillance. So that's with the upper scope and a special side viewing endoscope to look at the ampulla. That starts at age 25 and every 1 to 3 years repeated. The only time we do it earlier is when the person is going for surgery. We will do one side viewing exam to look at the ampulla. If they have a tumor at the ampulla, you would need to add a Whipple surgery onto the colectomy. So that can change the surgeon's methodology. Thyroid. There is a 5% risk of thyroid cancer. There's no consensus on what to do. The standard is to do a thyroid examination. Some groups, Mass General Hospital at Harvard, will do a thyroid ultrasound every 1 to 2 years on all their FAP patients. They have described in their FAP kindreds or families in Massachusetts a very high risk of thyroid cancer that no other group has described. So again, is it an environment gene interaction, something in the Boston River that's causing it? Or is it something different about that family's genetics? Hepatoblastoma, we talked about that very rare liver tumor. We do screening with hepatic ultrasound and AFP between 0 and 5 years old, repeating every 3 to 6 months. So this is a patient we scoped just a few months ago. you want to press the video? So he had had a subtotal colectomy. He had rectum and all of his sigmoid colon, maybe a bit of his descending colon left. And for whatever reason, after the subtotal colectomy, decided not to have surveillance for 9 years with a colonoscopy. So then this is what he had. This is us retroflexing into rectum. You can see all the polyps. That largest one off to the left-hand side turned out to be invasive adenocarcinoma with positive lymph nodes. So he's a person that probably should have received a total colectomy with a J pouch off the bat. And if he did get a subtotal as he did, he should have had colonoscopy every year. And he was young. He was maybe 37, 38. He was much older than me, so. MYH-associated polyposis. So this is the third polyposis syndrome. It's similar to an attenuated FAP phenotype. Usually you get less than 100 polyps, 15 to 100 polyps in it. Older age of cancer onset in their 50s. Unlike FAP or Lynch syndrome, though, it's autosomal recessive inheritance, not autosomal dominant. So here, often you will not see an affected parent. Is both parents carry the recessive one bad copy of the gene, and it's that person's bad luck that both parents gave them the mutant copy of the MYH gene. There are two common variants of the MYH gene that are tested for by AROP, Mayo Labs, Myriad. These are the two common mutations, Y165C and G382D. The problem with this genetic testing is that those two mutations were found in a European population. We assume that it does not represent MYH polyposis in other ethnic groups, whether that's African Americans, Hispanics, Asians. Therefore, probably in the last month, Myriad and AROP have now gone to full MYH sequencing. They're no longer just looking for the two common mutations in the European population. They'll sequence the entire gene. So that's quite a bit better for trying to diagnose MYH-associated polyposis. So when you're thinking about genetic testing for FAP or attenuated FAP or MYH, what are the factors we think about? So if a person has 10 or more adenomas, and the actual guidelines from the GI societies are 10 or more adenomas over multiple colonoscopies. So if you had 2 colonoscopies at 50 and at 55, you came up with 10 adenomas, the GI guidelines would suggest that you consider FAP or attenuated FAP on your differential. Definitely, if you had 10 or more adenomas on a single colonoscopy at age 40 or 50, you should think about FAP. If you have 5 or more adenomas with a strong family history of colorectal cancer, again, you want to think about MYH polyposis or attenuated FAP. If it looks like a recessive pattern of inheritance, you can start with MYH. In general, the way this testing is done at Myriad and AROP, Mayo Labs, is if you send off for APC sequencing for FAP, if it's negative, they will automatically reflex and test MYH for you if you request it. So they'll either hold the blood and say to you, APC is negative, do you want to do MYH? Or you can order it like that, APC with reflex to MYH, and they'll do both at the exact same cost, the $1,500 cost for APC. So one last thing I want to talk about with genetic testing before we move on. So right now what I explained to you in terms of genetic testing where we ask for one gene at a time, whether it's one of the mismatch repair genes or APC or MYH, and we send it off to AROP or Mayo Labs or Myriad and say, sequence this gene, tell us if there's a mutation or deletion, and they thank us for the $1,500. That's going out. Coming probably in the next 1 year, there's a group at the University of Washington and another group, a biotech company, that have come up with chips, essentially, where they will test 20-plus genes at the same time. And the panels are breast cancer panel, colon cancer panel, or anything else kind of panel. But the colon cancer panel includes about 20 genes, including APC, all 4 mismatch repair genes, MYH, plus the genetic test for Poitz-Jager's, juvenile polyposis, Cowden syndrome, all built into one test. They priced it right now at $2,000. So the feeling is it's a little, if you know the patient has FAP, you're better off still doing APC sequencing alone. If you're unsure, is it Lynch syndrome or FAP, or you're alternating between 2 different things, you're better off with the panel. And the feeling is in 1 year, they'll bring that cost down to $1,500, and we'll just all go to that, where we'll pick the colon panel and do all the genes for colon cancer off the bat in one shot. So, serrated polyposis syndrome. This used to be called hyperplastic polyposis syndrome. This is a very rare genetic syndrome. So the typical patient that we've seen is a 56-year-old, in this case 56-year-old female, whose family history has an aunt with colorectal cancer in her 60s, maternal grandmother and grandfather with unknown cancers. They come for screening colonoscopy to me. In February, they were found to have 11 sessile polyps, all small, turned out to be serrated adenomas. Came back in June because I was unsure with the prep if I'd cleared the colon. Again, this time with a better prep, I find 34 sessile polyps, all small again, come back as serrated adenomas. And I bring them back 6 months later, so I'm worried, why were there that many polyps? 16 polyps this time, all serrated adenomas again. So you can see when we talk about these sessile serrated lesions, they're very hard to spot because they're not the typical pedunculated polyp. They can meld into the wall of the colon. The top two photos in green are using a different type of imaging called narrow band imaging that can help gastroenterologists find these lesions. So just some more pictures of this. Generally, the guidelines right now, there's no genetic test available. The guidelines are if you have 5 serrated polyps proximal to the sigmoid colon, or you have 20 or more serrated adenomas throughout anywhere in the colon, you give them a clinical diagnosis of serrated polyposis. In a variety of studies, the risk of cancer is anywhere from 0 to 77%. It's all over the place. We assume that people who have serrated polyposis have at least a 5-fold elevated risk of colorectal cancer. So we'll just go through this. So it's a newly identified clinical polyposis syndrome. It's very important to recognize them from either the colorectal surgeon, the pathologist, and the gastroenterologist point of view. They do seem to have an increased risk of colorectal cancer of 5-fold, and they may have extracolonic cancers. The few case series done from Cleveland Clinic, Johns Hopkins, and us basically show these patients seem to get a variety of tumors, breast, thyroid, endometrial, lymphoma, all more frequently than you would expect in the general population. The management has been surveillance colonoscopy every 1 to 2 years and surgical management with colectomy if the polyposis is too extreme. The last group to briefly talk about is the hamartomatous polyposis syndromes. So Poitz-Jaeger syndrome, autosomal dominant, easy to recognize in terms of getting macules, purple-colored macules around their buccal mucosa and their mouth. The gene is STK11. In Poitz-Jaeger's, the major risks are colon cancer, pancreatic cancer, stomach, and small intestinal cancer. So juvenile polyposis often will come from even pediatric gastroenterologists referring to us, is they find these large juvenile polyps in the colon in a child who's presented with bleeding or bright red blood. They have a 40% lifetime risk of colon cancer, a significant risk of gastric cancer. There are 2 different genes that are mutated in these patients, SMAD4 and BMPR1A. The interesting thing is the gene that causes juvenile polyposis is the same one that causes hereditary hemorrhagic telangiectasia, HHT. So you can see both of those disorders in the same patient as well. We'll skip over counts, it's rare. The last thing I want to touch on is common familial colorectal cancer. This is what we'll see in our GI practices, our primary care practices, more frequently than all of these hereditary syndromes. This is where you have colorectal cancer and there's a first-degree relative with colorectal cancer, or having a first-degree relative with colorectal cancer, what's the elevated risk? And that's what your patient's going to ask you. So if you have one first-degree relative with colorectal cancer diagnosed below age 60, your risk of colon cancer goes up 3-fold. If you have 2 first-degree relatives with colorectal cancer diagnosed at any age, your risk goes up 3-fold. And that's usually where we draw the line as to earlier and more frequent colonoscopy surveillance. If you have 2 first-degree relatives with colon cancer or 1 first-degree at a young age. So the guidelines are if you have a first-degree relative with colorectal cancer at age less than 60, to start colonoscopy at age 40, or 10 years earlier than the youngest person with colon cancer, and repeat every 5 years. It's the same if you have a first-degree relative with an advanced adenoma. This is an adenoma that's large in size, has high-grade dysplasia, or villus histology. You start at age 40 in the first-degree relative and repeat every 5 years. Previous guidelines had said anybody with colorectal cancer as a first-degree relative should start colonoscopy at age 40. This is no longer the guideline. So if your relative got colorectal cancer over age 60, you would still follow the standard screening guideline of age 50. This may change in the next iteration of the surveillance guidelines based on family history. There's quite a bit of data that's kind of in press right now saying that even if you get colorectal cancer over age 60, your first-degree relative's risk is elevated. So this is our family cancer assessment clinic. You can talk to me about cases, but if you have any patients with inherited syndromes that you're worried about, please feel free to give us a call. That's it. Questions, or did I answer everything? EGD is reasonable to do. It's not part of the guidelines, though there is an increased risk of gastric cancer. So we will at least do one baseline EGD in a Lynch syndrome patient. The reason we don't do surveillance EGDs is because nothing has ever been shown to prevent gastric cancer. We are not clear about what the precursor of gastric cancer is. Is it a polyp, or what kind of polypoid lesion is it? So nothing's ever been shown to prevent gastric cancer. So this goes back to the research and prevention. Don't do a test if you can't prevent what you're looking for. So if we had a good test to prevent gastric cancer, we would offer it. Capsule endoscopy. Capsule endoscopy has been looked at both with FAP and Lynch syndrome because both of those groups have an elevated risk of small bowel cancer. The problem is the capsule is flipping around into small bowel, and the images aren't great for finding small polypoid lesions. It again has never been shown to be effective. What has been shown to be effective in Lynch syndrome for surveillance, actually, most gastroenterologists, including, I'll tell you myself, I don't do it, is to spray indigo carmine in the colon while you're doing the colonoscopy and look at the colon under normal white light, which is the normal way we look at the colon, and under indigo carmine dye, which highlights up dysplastic or malignant tissue. The problem with indigo carmine in GI practice is it takes up too much time. You have to spray it on, wash it off. It's just not a cost-effective thing from the gastroenterologist or probably the ASC or hospital's viewpoint of you doing the economics of healthcare.
Jewel, what we encounter sometimes in practice, and I think in private practice, is a patient is diagnosed with colon cancer. And then they say, well, what is the risk to my family members, and how do I go about getting them tested or introducing that subject? So maybe just comment on that. What do you do, and what kind of conversation do you have with family members of someone who has colon cancer?
Perfect. Great question, Chad. So we will often, at least in our genetics clinic, we often all have the entire family with us. But if only the affected individual is there, while we're talking about colon cancer, we will tell them that there is a genetic basis to colon cancer. We know it can be transmitted in families. There are a few of these rare genetic syndromes, but even apart from them, your close relatives are at least 2 to 3-fold more likely to get colon cancer than the average person in the community. Would it be a good time? What would be a good time, or at the next appointment, maybe you could bring your kids in or your siblings, or we could set up an appointment to talk about them. We also have kind of like pre-made form letters that we'll often give the patient that they can give to their siblings to contact us to assess their colon cancer risk. At very least, you need to have the discussion with the patient that their siblings and children are at elevated risk and should get colonoscopy starting at 40, and what's the best way to get them in, for them to contact their relative and have them contact your office to get in for a colonoscopy. I really think that's the biggest hurdle. Is if you're not having rectal bleeding, people don't like the idea of going in for a colonoscopy unless they have to.